I'm very pleased to introduce my co-organizer, Dr. Gabriella Gobbi. She's built a career largely based on testing potential novel antidepressants. Where are we? There we go, yeah. For the novel compounds for the treatment of mood and anxiety disorders. The creativity of this work has led to the receipt of a number of awards, including most recently a prestigious prize from the Graham Beck Foundation. Today, Dr. Gobbi will summarize a series of studies investigating the endocannabinoid system, both as a potential cause and cure for mood and anxiety disorders. Gabriella.
Thank you, Marco. Good evening. So let's talk today about cannabis and mood disorder. That was my topic of research in the last 15 years. This is my conflict of interest. I have no conflict of interest with this cannabis topic. So today we try to answer 3 questions. Does cannabis have antidepressant properties? Can doctors use THC or cannabidiol in clinical practice to treat patients with depression or anxiety? Does cannabis produce depression in adolescents? The first question, actually the first psychiatrist that asked this question was Jacques Moreau-Detour, that in 1845 he went to India to pick up some cannabis, he came back to Paris and tried cannabis, THC, in patients with depression. I describe very well what he found. He found 4 patients with depression that responded very well to THC. Instead, 4 patients had panic attack and the depression became even worse. So in my laboratory, for many years, I asked the same question. Does cannabis have antidepressant effect in laboratory animals? So we study, as you know, I was told today, cannabis has 2 main components. The first one is the THC, that is a CB1 partial agonist, and then the cannabidiol, that is a 5-HT1 partial agonist. Only high doses become a CB1 agonist. And then we use the WIN, that in black market is called as Windex, that is a synthetic CB1 agonist. So first we study the response of cannabinoid in a serotonin system, because as you know, serotonin is the main neurotransmitter implicated in depression. So using electrophysiology, we were able to record the firing activity of serotonin in dorsal raphe. So what we found that actually THC at low doses, 1 milligram kilo, increase the serotonin firing. And this effect was blocked by rimonabant, that is a CB1 antagonist. We test also WIN, that is CB1 agonist, and THC at higher doses. And in both cases, THC and WIN at low doses increase serotonin, but then if you increase the doses, you have a down in serotonin. We study also cannabidiol, the non-addictive component of cannabis. This study was done by Danilo De Gregori in my laboratory, not yet published. And what we found with the cannabidiol, we have an effect similar to SSRI or Prozac. So you have in acute a decrease of serotonin firing activity, but after 7 days of chronic treatment, the serotonin activity recovers and you have an increase. So since we can't ask rats, how do you feel today? So we use a behavioral test that consists called a force swim test. You put a rat in a condition of stress, then the day after you measure the immobility, the swimming activity, and the increase of immobility is a sign of depression. So what we found with the WIN is that WIN acts as desipramine and citalopram. At low doses, you have an increased activity in swimming, but if you increase the dose, this activity disappears. And this effect, this antidepressant-like effect, was mediated by serotonin. In fact, if you do the lesion of serotonin with the PCPA, this effect disappears. Again, with the THC in acute, after single exposition to THC, we don't have any effect in force swim test. But after 4 days of a repeated administration of THC, you have a huge antidepressant-like effect, very comparable with the citalopram. So, a lot of studies in the last 10 years in my laboratory, they found this effect for THC, WIN, and cannabidiol. So you can see that low doses, both THC and WIN increase serotonin, but at high doses, they decrease. In chronic treatment, at low doses, THC increases serotonin, WIN was not tested. We found that it's true in the short term, THC has antidepressant-like effect. Instead, WIN has antidepressant-like effect only at low doses, not at higher doses. Cannabidiol, that is non-addictive component of cannabis, seems to act as SSRI. So it means in short term, low and high doses decrease serotonin, but after chronic treatment, increase. Now, in our laboratory, we're testing also the property of cannabidiol. It seems that antidepressant effect is quite weak. Instead, anxiolytic effect, in particular in neuropathic pain, seems more promising avenue. And these data are also confirm also the observation in clinical trials. So the second question, you have a lot of patients that ask you, doctor, can I take THC for depression? So what we know about this? We have a lot of anecdotal evidence that THC can help depression, anxiety, but all these studies that were published are anecdotal or are done in people with multiple sclerosis, HIV, and pain. We don't have a study carried out specifically in depression. So Whiting et al. In 2015 in JAMA did a big meta-analysis to find the effect of THC and cannabis in medicine, in particular in depression. So they didn't find any randomized clinical trial. So there are no randomized clinical trial in depression. So what Whiting found, they found 5 clinical trial randomized, but not in people with depression, in people with cancer pain, chronic pain, multiple sclerosis, and depression. They use some scale as MADRS, HADS, Beck, to measure the effect of on depression. Actually, only with Sativex is a mixture of THC, cannabidiol, they found a low effect in depression. As you know, to have a significant effect in depression, MADRS must change at least 4. With the THC, they found a negative effect, so THC is even was worsening depression, and almost no effect with Sativex in multiple sclerosis. So, what the Academy of Science, the National Academy of Science concluded in 2017 about this, say there is limited evidence that Sativex, THC, Nabilon are ineffective treatment for reduction of depressive symptoms. That it means that now we have no evidence, no evidence-based medicine for use THC in depression, and we need more clinical trial for specific population in depression. There was also this paper published in 2011 by Bergamaschi using 600 milligrams of cannabidiol for patients in social phobia. It seems actually promising, but still this is a small trial done in about 25-26 patients. Still, we need more clinical trial that cannabidiol could be used for anxiety. So my conclusion now is that at present there are no clinical trials in patients with major depression. Tools for evidence-based medicine for the use of cannabinoids in depression does not exist. And given the double-aged results of CB1 agonists in laboratory animals that sometimes can increase serotonin, decreasing serotonin, or give antidepressant effect or depressogenic effect. Still, we should be very cautious to use a THC for depression. Cannabidiol seems to be a more promising agent for depression, but still we need clinical trials. Finally, the third question we asked in our laboratory was if cannabis produced depression in adolescents. As you know, as was told, was said today, Canada has the highest prevalence of use of cannabis in adolescents in the world. So the prevalence in the last census in Canada was 26% of adolescents that use weekly cannabis. Anyway, it was decreased compared to 2008. The mean age of first cannabis in Canada is now 15 years old. In Quebec is 13.5. And then we know that the use of cannabis then decline. If you see this study done in the United States, as you see in orange, you have the THC, the peak is between 15 and 25, and then declines. Instead, you see tobacco and alcohol continues during life. So, as you know, the adolescent brain is under development, so it's logical to think if you introduce a drug of abuse during this time, you can compromise the development of the brain. So, in our laboratory, we asked to our rats, what's happened if a rat smoke from age 30 days postnatal to 50, that is adolescent rats, if smoke every day as kids that smoke a joint every day, what's happened in adult life? So we administer THC or WIN every day in these adolescent rats, then we stop. We went to see if in adulthood, in a young adulthood, they were depressed. Again, we measure serotonin. So you can see these are rats that smoke cannabis, consume cannabis only during adolescence, and then they stopped. But still, you have a dramatic decrease of serotonin firing even in young adulthood. Instead, if we injected starting adulthood with cannabis, the serotonin doesn't change. We did also this first swim test. And these rats in adolescent were actually a little bit depressed, but the more interesting data was about anhedonia. In fact, somebody asked about the subtle symptoms of adolescence. So what we found is not that cannabis, the effect that we saw in depression was not so strong as the effect we saw in the anhedonia. In fact, it's reported that depression caused by cannabis is not the depression that you are negative, you want to kill yourself, but is anhedonia, or it's called also a motivational symptoms. Here there is Dr. Negrete, who was one of the first in the 60s to describe this amotivational syndrome. Is the classical guy that is always in front of a TV, in front of a computer, just doing nothing, that doesn't know what to do in life, has no project. This is the big effect that we also saw in animals of cannabis. So we can say that cannabis adolescents produce a decrease in serotonin spontaneous firing activity is paralleled by this anhedonic antidepressogenic effect. So, but we were not happy. Say, can we replicate this data in a human population? So we decided 2 years ago to start a meta-analysis that we're lucky were sponsored by the CHR. So we asked this question, the same question we asked to the rats. So does cannabis smoked during adolescence increase the risk of developing depression in young adulthood, in absence of a premorbid condition? So exactly the same question. So we decided to take all the longitudinal prospective studies done from age 13-18 to age 24-30. Okay, we select only the longitudinal prospective study that study the adolescents that start to smoke cannabis during adolescence, then they stop, they continue, and we saw the outcome at age 24-30. So we found 3,142 studies, 265 were assessed for eligibility. At the end, we end up with 13 studies. So what we found this higher incidence of depression in young adulthood. So I repeat, these are people that even stop to smoke cannabis in adolescence. So what's happened between ages 24 and 30? So we have a OR or the risk of 1.3 and a relative risk of 1.3. So then I asked to the epidemiologists, I'm not an epidemiologist, what does it mean, this number in Canada? So they did the calculation for me. It means that if you consider that Canadian adolescents smoke cannabis about 22-26%, if you calculate the risk ratio, means that 6% of depression in young adulthood is attributable to cannabis. So if you think we have 5 million young adults in Canada, 5.4% of them are depressed, we have 16,000 patients that are depressed just because of cannabis. So we have these people that should not be depressed because they are not family risk, because they didn't smoke a cigarette, because they have a good social demographic condition. But these 16,000 just caused by cannabis. As you know, to suffer from depression from age 24 to age 30 is a big risk because it means you fail school, you don't finish university, you have difficulty to find the first job, to start your relationship life, etc. This risk seems to be also correlated to the frequency of cannabis and seems even higher in teenager girls. Then we also look at the suicidal attempts. Here we have even odd risk even higher, about 2.85. As well as a suicidal ideation, we have a risk of 1.65. Again, these are people that should not be suicidal because it was adjusted for everything. So there is still, even if the odd risk is low, but it's still high compared to the population that smoke cannabis. Even anxiety, we find 1.2. So what I can say, this meta-analysis study indicates that cannabis during adolescence increased the risk of developing depression, anxiety, suicidal behavior in young adulthood, even when adjusted for premorbid depression, anxiety, gender, socioeconomic status, cigarette, alcohol, inhalants, etc. Take-home message. So what we can say that both synthetic cannabis and THC increases serotonin at low doses and decrease serotonin at higher doses, and this may correspond to an antidepressant effect at low doses and depressogenic effect at high doses. More research, we need to validate the use of cannabidiol in depression, and there is a distinct effect of THC on depression in young people versus adult subjects. THC during adolescence causes depression even in young adulthood, even if the use of cannabis is discontinued after 18 years old. Finally, I would like to thank all these people that work very hard to inject the THC to all these animals, to read 3,000 papers in 1 year, Tobias Atkin and Thomas Zitinsky. And thanks to Fonds de la Recherche Santé Québec, yesterday we have the news that the Ministère de l'Économie, Sciences et Innovation sponsored to us a clinical trial with the cannabidiol. Thank you for the CHR for sponsoring this meta-analysis. Thank you to Nancy Mayo, is our epidemiologist, and Nandini that helped in this analysis too. Thank you. Yeah.
We have time for 2 questions.
Told us about the bad side of cannabis and youth.
Yeah.
You've told us about the bad side of cannabis in youth, of how it can cause depression in a small number of people. What about the other side? Is it possible that taking cannabis can be a preventive action and stop people from having depression? In other words, how do we look at the total picture is my question.
Yes, I didn't present all, but yeah, there are some studies that say that actually adolescents smoke cannabis to have the high, to feel relaxed, to recover from depression. Yes, in the short term, it's true. Adolescents use cannabis to feel better, to lower anxiety, to sleep better, etc. But the problem is in long term, what happens. So there is a good side at the beginning of a THC, but it's not the way to treat depression.
We don't know the long-term effect on the positive side. We only know the long-term effect on the negative side.
Yeah.
But it's possible that has it prevented depression?
Okay, so as you see, the meta-analysis is more than one. If it was prevent, it should be less than one. Unfortunately, the data are this. The data say that for depression, cannabis is not good. This is what the data say. If was true your hypothesis, so the meta-analysis, the odds ratio should be less than one. It's correct. In this case, it should be preventive for depression, but the data, they don't say this. We don't have one single, maybe there is only one study that this is good because it was done, they look at people from adolescent to age 50. So this study was negative, was the only negative study, but you see, we have 37 studies, epidemiological, longitudinal studies that say all the same. Sorry? Yeah, okay.
Thank you, Gabriella. Yeah. So my clinical impression, at least from what I see patients reporting often, is that the effects of cannabis is more prominent in the anxiety symptoms rather than depression. And often it's used by patients as an hypnotic, to help them relax and sleep. So I was wondering, what your thoughts were on that, as more as starting as an antidepressant per se, but more as an anti-anxiety effect and hypnotic.
Yes, one of the short-term effects of THC is the effect of anxiety. For this reason, patients use a lot of THC, and the effect of sleep. It's true, the effect of sleep are very positive. THC, also cannabidiol, has positive effect of sleep. The problem is, in the withdrawal, if you stop smoking cannabis, you start to have nightmare, your sleep is completely disrupted, so your sleep becomes dependent from cannabis. In the withdrawal, you have a disruption of sleep architecture.
The effect or not?
Yes, it's a tolerance effect. It's a tolerance effect and then a withdrawal effect, yes. Yes, exactly, it's the same, yeah.
Are there any other questions? No, thank you very much.
Okay.